Hello dear viewers, in this video I am going to discuss an updated guidelines on the management of venous thromboembolism prophylaxis in critically ill adults in ICU. I am Dr. Sunil Garg from Essentials of Acute Care. Here I will discuss most recent guidelines of 2024. Venous thromboembolism includes deep vein thrombosis and pulmonary embolism. Deep vein thrombosis commonly occurs in the veins of lower limb and pelvis, and the incidence of venous thromboembolism in ICU is high and vary between 10 to 90%. It is significant cause of morbidity and mortality. The common risk factors which are associated with the increased risk of venous thromboembolism for patients who are critically ill are mainly divided into two categories. First category include risk factors which are present in patients prior to admission to ICU, and other category of risk factors are specific to ICU setting. The risk factor in the first category or pre-admission category are recent high-risk surgery, sepsis, trauma, stroke, cancer, advanced age, cardiac and respiratory failure, and underlying disorder or medication, and prior history of deep vein thrombosis or pulmonary embolism. The risk factors which are unique to ICU settings includes the use of sedation, muscle relaxant and vasoactive medication, sepsis, cardiac or respiratory failure, immobilization, mechanical ventilation, renal insufficiency or hemodialysis, central venous lines, and invasive procedures. On comparing pharmacological prophylaxis with mechanical prophylaxis, guidelines recommend the use of pharmacological prophylaxis over mechanical prophylaxis in ICU patient if there is no contraindication to pharmacological prophylaxis, as it is more effective. With regards to comparison of mechanical prophylaxis versus no prophylaxis in patients who have contraindication to pharmacological prophylaxis, there are different statements for surgical and medical patients. The statement for surgical patient is in favor of mechanical prophylaxis at the level of recommendation, while for the medical patients, the statement is at the level of suggestion in favor of mechanical prophylaxis over no prophylaxis. With regards to choice of anticoagulants in different conditions and situations in ICU, guidelines recommend low molecular weight heparin over unfractionated heparin. In patients with severe renal dysfunction, guidelines suggest either unfractionated heparin or deltaparin over other low molecular weight heparin in ICU patients. Ergotraprane is recommended as first-line option in ICU patients with heparin-induced thrombocytopenia. With regards to choice of mechanical prophylaxis, guidelines suggest using intermittent pneumatic compression rather than graduated compression stocking in ICU patients receiving mechanical prophylaxis. Regarding the use of combination of prophylaxis, means combination of mechanical and pharmacological prophylaxis, guidelines state that combined mechanical and pharmacological prophylaxis is suggested in selected patients who are at very high risk for venous thromboembolism, particularly critically ill surgical patients like orthopedic surgeries. And if combination is used, then the use of intermittent pneumatic compression is suggested rather than graduated compression stockings in addition to pharmacological prophylaxis. Regarding dosing, the guidelines suggest intermediate dose of low molecular weight heparin over a low dose in ICU patients receiving pharmacological prophylaxis. Following an individualized risk-benefit analysis, the common low molecular weight heparin includes enoxaparin, bemiparin, deltaparin, tinjaparin, and natroparin. All low molecular weight heparin can be given as a single subcutaneous dose. We most commonly prescribe enoxaparin in the dose of 40 mg once a day for averagely built individual, while for overweight individual the dose is 60 mg. Regarding monitoring the dose of low molecular weight heparin, the guidelines do not suggest routine monitoring of anti-factor Xa levels in patients admitted to the ICU receiving low molecular weight heparin as a thromboprophylaxis. However, the guidelines suggest anti-factor 10A level monitoring in selected cases admitted to the ICU and receiving low molecular weight heparin as prophylaxis, and it includes selected cases of renal impairment or morbidly obese patients. In such patients, anti-factor 10A level dose adjustment protocol is suggested. The peak value of anti-factor 10A of 0.2 to 0.6 international unit and trough level of zero point 0.1 to zero point 0.2 international unit per ml is suggested. The peak value is measured 3 to 4 hours after the dose. Here I finish. Thanks for watching this video, and please do not forget to subscribe to this channel. I would appreciate your feedback, suggestions or comments. See you again in my next video on high flow nasal cannula. Till then, bye and take care.